Good morning, ladies and gentlemen. Dear colleagues, my name is Antonia Kristic from the Department of Biomedical Imaging and Image-Guided Therapy from the Medical University of Vienna, and my topic is the efficacy of MRI in the non-invasive differentiation between focal pancreatitis and pancreatic cancer. Let me start with some background information first. The differentiation between focal, or the so-called mass-forming pancreatitis, and pancreatic carcinoma poses a great diagnostic challenge for every radiologist. Therefore, an early and accurate diagnosis is crucial to achieve the optimal management for these patients. A correct diagnosis is important, as focal pancreatitis is treated conservatively and requires a follow-up, whereas the pancreatic carcinoma is managed more invasively with either operation, if it is still resectable, or only palliative treatment with chemotherapy in advanced cases. To make this challenging diagnosis, there are a large variety of diagnostic options that include non-invasive procedures with imaging modalities, such as the conventional ultrasound, the CT, MRI, and also PET-CT or PET-MRI. And in some cases, however, we need invasive procedures, which may include the ERCP, the endoscopic ultrasound, and also the EUS-guided biopsy. Thus, the aim of our current study was to evaluate the efficacy of MRI in the non-invasive differentiation between focal pancreatitis and pancreatic cancer. We examined 96 patients, and of these 55 were males and 41 were females. All participants underwent an MRI examination in the period from 2007 until July 2019, and the mean age of a cohort was 60 years. The histological diagnosis was a gold standard, which was acquired via surgery in 74 cases and via biopsy in 21 patients. Coming to our methods, MR images were evaluated retrospectively by one reader, and we used descriptive statistics, including the Pearson chi-square test, the Fisher's exact test, as well as the student's t-test, logistic regression, and decision tree approaches. MRI exams were acquired on a 3 Tesla machine. We administered gadoxetic acid as a contrast agent to all patients, and in addition, 53 patients received IV secretin for functional imaging of the pancreas. The MR protocol with the exam parameters is shown in this table. And now, coming to our results, the majority of the benign pathologies were chronic pancreatitis cases. In the group of the malignant diseases, the majority, nearly 90%, were deemed ductal adenocarcinoma histologically. We observed 32 true benign or negative and 50 true malignant or positive lesions when comparing the retrospective MRI analysis and the histological exams as the gold standard. In total, 11 subjects were rated malignant in the MRI, although the histology showed a benign entity. However, 3 patients were false negative. The statistical analysis using the chi-square test showed an accuracy of 85.42%, a sensitivity of 94.34%, and a specificity of 74.42%. For the differentiation between malignant and benign lesions, vascular infiltration and irregular margins were significantly more often found in malignant lesions and therefore were considered a feature of malignancy. In this example, we can see a coronal and an axial contrast-enhanced image. On the left image, we can see a pancreatic tumor with infiltration of the celiac trunk and the superior mesenteric artery, in other words, vascular infiltration. On the other side, we can see the irregular margins of the pancreatic adenocarcinoma. However, calcifications and homogeneous lesion morphology were typical for benign lesions. Again, let me demonstrate both features to you using this example. On the left side, we see a benign focal pancreatitis with homogeneous lesion morphology. The MRCP suggests a calcification in the duct that was further confirmed by the CT, which is the ideal tool for the detection of calculi. Further MRI features were the DWI and the contrast enhancement pattern, with malignant lesions presenting a hyper-intense appearance with B values of 300, and an inhomogeneous enhancement on the arterial face, as we can see in both images. When assessing the pancreatic duct morphology, stenosis and occlusion were found in malignant entities or in adenocarcinoma. The duct penetrating sign, on the other hand, was observed in benign lesions. The sign is positive when a mass is penetrated by an unobstructed pancreatic duct, and this makes focal pancreatitis the most likely cause rather than pancreatic carcinoma. These two MRCP images clearly show the occlusion of the pancreatic duct by a ductal adenocarcinoma on the left side and only a narrowed pancreatic duct caused by a focal pancreatitis that nevertheless penetrates through a mass on the right side, which is the duct penetrating sign. We also evaluated the added value of secretin-enhanced MRCP and found that malignant lesions showed a larger lesion size compared to benign ones. The duct width was also found to be greater in malignant lesions. Let me show you a very nice example demonstrating the added value of secretin. We see the large mass in the pancreatic head and in the Antonia process. A differentiation between malignant and benign mass is not possible here. However, if we analyze the secretin MRCP, we recognize the duct penetrating sign. In other words, the whole duct is visible and no occlusion is present. And this is a confidence sign of benign entity. So, dear colleagues, I hope that I have shown you our results, explained by some nice examples, which lead me to conclude that MRI, in particular using the DWI and the secretin-enhanced MRCP sequence, is an important tool with which to distinguish between benign and malignant pancreatic tumors, and in particular the differentiation between focal and mass-forming pancreatitis and pancreatic cancer. Our study has a few limitations as well. We had only one reader, and thus there could be the question about the robustness of our results. Secondly, gadoxetic acid was used as the sole contrast media. Calcifications are also a major limitation in the assessment with MRI. And furthermore, AI was not included for dynamic imaging and DWI, and all these limitations will be omitted in the final manuscript. Thank you for your kind attention.